Greetings, listeners, and welcome to the Caretable podcast, dedicated to educating and supporting family caregivers of aging loved ones. I'm your host, Amy Huddleston. Through insightful interviews from both industry experts and family caregivers, we aim to provide valuable perspectives and resources. Let's see who we're learning from today. Hi, welcome to today's episode of the Caretable. I'm very excited to talk about eye conditions for older adults, and I'm very grateful that we have Dr. Elliot Davidoff here, who's an ophthalmologist. And I'd love for you, Dr. Davidoff, to share, explain to us what an ophthalmologist is.
An ophthalmologist is a physician having gone to either medical school and then their MDs, or osteopathic physicians, which are DOs. Back in the Middle Ages, when I was in school, the education at the osteopathic schools was not as good as it has been as the MD programs. But over the last 50 years that I've been in this business, I can say I see no difference in the educational levels between the osteopaths and the medical doctors.
So one question I want to ask before we get into the different eye conditions of older adults, because our audience is caregivers, we want to educate people. I was curious to ask you, we've got two different types of eye professionals that older adults can see. They can see an ophthalmologist and they can see an optometrist. And from what I gather, the optometrist is somebody that can just help me with check my eyes, do my vision test, help me with some glasses, but they're not an MD where they're going to help me, should I encounter some eye conditions that could be problematic. Would that be an accurate summary?
Yes, to a degree, they are licensed to provide care in certain medical conditions. However, they're more on the fixing people's eyes, examining them, fitting them with contact lenses, giving them glasses, helping them to see, things like that. Whereas we do that, but we also do invasive procedures to treat serious eye diseases. However, a serious eye disease, if it's my eye, it's serious. And that's how
Mine
everybody
too.
feels.
Yeah, you're exactly right. Well, then let's get into that about there's a lot of eye conditions that, people as they age will encounter. And I think some of the most prevalent I've heard of glaucoma, cataracts, macular degeneration, there's wet, there's dry. Are those probably the most common that you have seen in your profession?
I would say the big two are cataracts and macular degeneration.
Can you briefly tell us, I'm curious, when you hear wet macular degeneration and dry, what is the difference?
Okay, well, let's go back a step. The retina is that part of the eye, inside the eye, and when the light comes in to the eye through the pupil, it's focused by the lens of the eye and perhaps by contact lenses and glasses and things like that to focus the light on the eye. The part of the eye that picks up the images and turns it into nerve impulses is the retina. And the retina that is in the center of vision is called the macula. So what happens is, as we get older, we can very often get what's called macular degeneration. You can also have congenital macular problems, and you could have lots of other things. But macular degeneration is as it says, a degeneration of the most important part of the retina. And there are two forms of macular degeneration. There's wet and there's dry. Dry has no fluid coming out, no bleeding, not a slow but steady loss of the nerve cells in the eye so that the messages can't go from the eye to the brain, to the part of the brain that does vision. Just like when you take a picture with a camera, you've got the picture, but then you have to actually look at the picture in order to see it. And it's the retina in the eye, and the macula is the most important part of that. Now, you hear about macular degeneration because of two things. One is people are living longer, so they're more likely to get that problem. And secondly, there are now some treatments to prevent or make less likely and even to treat people who have lost vision or are losing vision, to stabilize them and sometimes even improve their vision.
Really?
Really.
Okay, when you first started, were those treatments around?
No.
Okay.
Actually, the first good treatment for macular degeneration came out in the year 2004. And it's how quickly they forget. What happened was, this was a medicine that was given to people, and it kept them from getting any worse. So in 2003, nobody used this. Then in 2004, it was the highest selling pharmaceutical in the whole United States.
Wow.
Up.
Wow.
And then in 2005, some very bright people from Harvard, one of whom, the leader, was from Central Ohio, uh, were using some chemicals to stop the flow of blood to tumors, thus shrinking the tumors. So they said, wow, if we can do this to the eye, we can stop these abnormal blood vessels. And they did this, and it's changed the world of ophthalmology.
And so it's an injection.
Yes.
Okay. Tell us, I'm just
Right
curious,
into the eye.
right into the eye. Does that hurt?
No, not if you're well numbed. And I've had 3 myself, so I can vouch for that. I have
Okay.
not given them to myself, however.
Okay.
I
Yeah,
would
that
have
would
if I
be,
could, but
oh my gosh. That sounds a little challenging, but I've always wondered, is that painful? I want to ask, I have a lot of questions around that. So when you're talking about the macular degeneration, are there any things that you recommend to people that help prevent getting macular degeneration?
yeah, there are some. It's called eye caps. It reduces the risk, but it is not it's not a true preventive. It reduces the chances of developing wet macular degeneration. However, I'm living proof that it doesn't always do that.
What is that when you're saying eye caps? What does that mean?
It's a name of a over-the-counter vitamin, eye vitamin.
Oh, okay. So it's a vitamin that you take daily that will help hopefully maintain your
Reduce
macular.
the risk,
Okay.
not prevent.
Okay. Okay. So now we've got some treatments on that. Let's talk for a minute though about that macular degeneration so that caregivers understand. From what I understand, your vision right in front of you is what really starts to go. You can maintain the peripheral vision, but it's hard to focus straight ahead. Would that be accurate?
Yeah, yes, basically yes. What happens is it, the macula is the part of the retina that deals with straight ahead vision, the central 15 degrees, shall we say, 20 degrees. So what happens is if you lose that, you still can walk around, you can get around, you have trouble reading, you can't drive a car, things like that. So it's really something to prevent, which we're not doing a good job of, but to also tr- diagnose promptly and treat aggressively.
Okay, so you say we're not doing a good job of helping prevent it. What do you think we could do better?
If I knew that, you'd have the Nobel Prize behind me.
Well, get cracking. What have you been working on?
Talking to you.
Oh, okay. Well then, okay, so we've got some work to do, it sounds like, in figuring out better ways to help. And I think like you said too, we're living longer. I mean, your body starts to age, these things obviously are going to happen. I would say in all of your years of experience, what is your advice when you've got caregivers that come into the office with you and the patient that you're treating is losing their vision, which is devastating? What advice do you tell a caregiver to help, especially when let's say it's happening a little more rapidly than they were hoping? What advice do you have?
Keep your appointments and follow through. And when we talk about injections into the eye, I mean, people freak out. People do not think well of it. It's better now than it was 20 years ago because everybody knows somebody who had it. If you're in the 60s, 70s, 80s, you know people who are getting it.
Mhm.
And it's really been a wonderful breakthrough.
Now, when you're getting that injection, how long does it last before you have to come to get another one?
Well, generally we start off with 3 monthly injections,
Okay.
and then a lot of us would do treat and extend. In other words, well, let me back up a bit. The best way to tell if there's active fluid is to do a test called an OCT. And OCT is an imaging of the eye, and you can see fluid underneath or within the retina, and it helps you make the diagnosis and also to see if they're getting better or not getting better, uh, like that. So, in an ideal situation, somebody comes in and they have fluid underneath their retina, and it was found because they said, my vision's a little wavy, it's a little blurry right in the middle, and then we do the scan, and then we know. So we'd give an injection, come back in a month, repeat the scan, but regardless, give another injection, and then another month, same thing. After 3 months, if they're dry, instead of having them come back in 4 weeks, we might make it 6 weeks. And then that's called treat and extend. If they come in 6 weeks and they have no fluid, okay, come back in 8 weeks. And then we try to get it to maybe 4, up to 4 times a day, which is every 3 months, or even more, 4 times a year. And there are also newer forms of the medication that seem to last a little bit longer. So people may get a greater interval between their injections.
Okay. So let's assume I, I'm a caregiver for my mom and dad, and their eyes are pretty healthy. Should they see an ophthalmologist annually? Like, what's your recommendation when you have your vision's pretty good and your eyes, your everything's going pretty well?
Uh, yes, people with this should get a yearly eye examination, and I'd say everybody should just about always, at this point in our knowledge, have a scan because you can pick things up that you might otherwise miss that you can't see with the naked eye or with our instruments, but with these imaging techniques, they've changed everything.
Is there an age minimum though that you recommend when you do the scan on a patient?
It's just the older you get, the more likely you are.
Okay.
And in my case, since I recently diagnosed myself, one morning I was reading the newspaper and I noticed a dark spot. So I'm retired now, but I went over to the office and I had them do a scan on me. Yeah, no waiting when you're a big shot like me. And then I saw the fluid, and before the day was out, I had an injection.
Wow. but you knew. So it's I think that's good advice for people that it sounds like so you saw a dark spot. What are other symptoms that people should keep an eye out for?
Well, that's not the usual way it presents. Of course, I
Oh,
have to be different. The
okay.
most usual thing is to look, and there's a thing called a grid with lines this way and this way, and you stare at a dot in the center. Don't scan the page. Look right at the dot, and all the lines should be perfectly square. But if they're a little bit wavy at any point, get yourself in to an ophthalmologist.
Okay. That's helpful. So the lines look wavy, but you mentioned the dark spot. Are there any other symptoms that people experience, whether it's macular degeneration or not? What are the symptoms that you most
Just
commonly,
not
should look out
seeing
for?
as well as you would like. And that could be
Okay.
from something else. I'd say the most common cause of reduced vision is cataracts. And when I started in my training in 1974, they would take out the lens of the eye, and people would have to wear glasses afterwards with big, thick lenses, and the vision was big. Everything was enlarged, big barreled, and bright because more light got in. And then soon after I started, we started, when we took out the lens of the eye, putting in a plastic lens to replace the natural lens. So people not only were seeing better, they were actually seeing better than they ever saw in many cases.
Is that still the procedure? It's a plastic
Yes,
lens?
yes. But there are some acrylic, plastic, but artificial lens, let's call it.
I just find that procedure fascinating to me that somebody was the first person that said, "Go ahead, slice my eye, give it a try, and let's hope that it works." I just find that fascinating, but I'm thankful because clearly it's changed a lot of lives. I've seen it personally of just like you said, they say, "I've never seen this well in my entire life."
Yeah, well, the first ones were done by an ophthalmologist in the UK. He had seen pilots with the Spitfires in World War II that had glass fragments in their eye after crashing or something like that. And the eyes tolerated the glass very well. So he made a lens. It didn't really work well, but because of other reasons. But it was known then that that was a useful uh, instrument. What do you call it? Useful thing that could be made into a lens. And then in the mid to late 70s, it started catching on more and more. And by the early 1980s, it had won over. It all happened so fast because the patients knew that they were getting better. With vision, you can tell you're seeing better than somebody who had their cataract surgery who didn't have that lens put in their eye.
It's amazing, honestly. I mean, actually, I remember my father-in-law saying, I didn't realize that Nana's robe was pink. Like he never even, he couldn't see the colors right, and so he just was like, it was such a great day for him, where he was like, "Look how bright the world is." I mean, it does make a big difference.
Well, also, if you're typical lens, the eye gets a little yellow and then more yellow and ultimately brown. If it gets to white or black, you can't see anything. But nobody really, in this day and age, lets it go that long because the word is out that you can be fixed. But in the old days, people would wait and wait and wait. They used to say you had to wait until it ripened. What that really meant was you had to be so bad off that if the surgery didn't work, at least you were no worse off. You couldn't see either way.
Oh my goodness. And what's it's a pretty quick recovery. Is that correct?
Yeah. Back in about the mid 80s, I'd say, um, we stopped. Actually, that was one time I was first in something. I think I was the first in Central Ohio not to put patches on eyes after eye surgery, and and not to use needles to numb the eye. So with that, I've had people go out after surgery. They went out and played golf.
That day?
Yeah, I wouldn't go out. I hate golf, but they loved it.
But I mean, that day. So they went in that morning, left, and went and played 9 holes.
Yeah,
Okay.
maybe 18. I don't know.
Okay. So it's that fast. It's not really, there's not much downtime.
Not everybody,
Okay.
but some people did.
Okay. So you said so cataracts and macular degeneration were the most common that you saw. And when you the cataracts, is it really just I'm losing my vision? I mean, is that something you obviously see with the scans and things that you're doing? But how do people know they have cataracts?
Two ways. One is just I don't see as well as I used to see. It's dull, it's dim, or everything looks yellowish, or glare is killing me. Now, the lens is only maybe 10 millimeters in diameter. However, there are different kinds of cataracts. Some of them have like little bubbles on the back and they scatter light. So people might have good vision, but they can't see because the glare is killing them.
Oh,
And you have
yeah.
somebody else, everything just gets darker and darker and they can't see, or blurrier and blurrier. So, not even though the cataract's a tiny little thing, different ways of it can affect the vision. None of them are good.
No. Okay. But I've never heard the glare piece, so that was interesting. So, but it sounds like that's a pretty easy fix.
Yeah,
Okay.
it
So it's
is
like,
today because we have 45 years of experience of it, and the implants have gotten better over the years. Used to be they were big, and you'd have to put a big incision in the eye to put it in. And now they can roll up, and you push it in through a small opening. So it's a lot less invasive procedure.
that's fantastic news. Or let's talk a little bit about glaucoma. How do I know if I have glaucoma?
You got to go to your doctor. Whether you go to an ophthalmologist or an optometrist, you need to know because uh, glaucoma has been called the sneak. Uh, she takes away your vision, sneak thief of vision. Because what it does is, if it's just normal run of the mill glaucoma, we call it primary, meaning it's not secondary to any other factors, open angle, it's not anything the configuration of the eye. It just, you slowly lose nerve cells. And if you lose, you don't realize it in the beginning, and then you're in denial for a while. And it's because the pressure in the eye is too high for that eye to tolerate. So you have to bring down the pressure so as not to have the nerve cells damaged. So what happens is uh, it sneaks up on you and you don't realize it. So you have to have screening. And is a test called the visual field that everybody hates. You sit at a bowl and they flash lights. The machine does it, and you push a button when you see the light, and you don't push it when you don't. And if you're getting constriction of the field or some part of your field is missing, that can be glaucoma. It could be other things also. And if it is, it can be treated with drops, with laser, with surgery. But you can't have it treated if you don't have it diagnosed. So even people who don't know they or don't think they have any problems, when you reach a certain age, you should really get your eyes examined.
Okay, that's helpful. So, what about that? When you say drops, it makes me think of. I'm just curious. Have you ever been asked? There's people that hate putting eye drops in their eyes. I mean, it's just really hard for them. Do you have any advice for even a caregiver if you've got someone that
Get
you've got to
over it.
administer drops? Is that's your advice?
I mean,
Okay.
You know, you've got
I
to you've got a
I
drop
agree.
that is going to keep you from going blind. Are you going to do it? You know, denial. If the vision were blurry, they might feel different, but they think they're seeing fine. It's a problem.
Oh, that's interesting. So it's I would think that I see what you're saying. You probably think you're seeing fine because it's slowly progressing and
Yeah,
you're not realizing.
and it's constricting, so you don't notice that you're missing some of the periphery.
So interesting. That's actually a great point. So that's why you absolutely need to get your eye exam because you don't realize it. So my question on how to better to administer drops is get over it. That's the answer.
I'm very compassionate.
There's oh I kn- there's
Okay.
no like special tool or no special should they lay down on the couch? Should they is
There,
there a certain way?
there are different ways that different people can adjust to their way of doing it. And some people, if they're, if, there are other treatments. One is a laser treatment that's done in the office. And if you've got mild or early case, you can sometimes, by doing that, reduce the pressure to an acceptable level without needing drops. And there's also surgery. But if you don't like a drop, you probably aren't going to like having surgery either.
You're
But the
correct.
laser
Yeah.
is a good answer for many people.
Okay. So let's talk to now about I'm a caregiver, let's say, of somebody has vision loss. Things are starting to deteriorate, let's say with macular degeneration. Do you have any, effective tools or anything that you recommend for people that you found over the years that maybe caregivers found beneficial to those? Like you want to help maintain their independence as much as you can. So what are the best ways to do that for somebody that's experiencing vision loss?
Well, I would say the most important thing is early detection and prompt treatment whenever necessary or possible. Now, we were talking about the wet form of macular degeneration, and this is one that is has is it's more common. It causes more aggravation. There's another form of macular degeneration called the dry form, where there's no oozing of fluid. There's just a gradual reduction in the visual cells in the eye, and there's not much we can do for that. There are now, you can see them advertised on television, these injections for it. And from my understanding, and I haven't really reviewed all the data in the last year or so, that it's been shown to make the pictures better, but it hasn't actually improved the functioning better. And this is one of those things. It's just like it sucks to get older,
It does suck
but
to get
it's
older.
there are not that many people until they really got into their upper ages who have serious problems from the dry, but we still don't have good treatment for it.
So I'm hearing you say there are more successful treatments for wet
Yes.
macular degeneration than dry. Okay. Are there anything, we didn't talk yet about like with if you have diabetes, explain to us why you can experience vision loss from you're at higher risk, right? Of your vision
Mhm.
loss. Why?
Well, first of all, if you're diabetic, everything else can be worse with diabetes, particularly if it's not well treated. But what happens with diabetes, there's a loss of the circulation, and that's why people may sometimes have to have amputations, things like that. But the circulation in the eye uh, is impaired. So sometimes you can have what's called um, non-proliferative, which means that the blood vessels can ooze, and the retina, which is like the film in a camera, it can swell up and reduce the vision. So by keeping everything quiet, and by using laser treatment, you can reduce the leaking blood vessels and improve the vision. The other problem it can cause is because these blood vessels have, uh, because, excuse me, because there's poor circulation to the nerve cells, a chemical is released which causes blood vessels to grow. And then these can turn into leaking, swelling, hemorrhaging, and things like that. So these injections can help. Also, laser treatment, not necessarily to the abnormal blood vessels, but to the part of the eye that we don't use that much. We turn sick tissue into uh, dead tissue, and then there's no stimulus for the factors that cause blood vessels to ooze and leak and proliferate, so they can shrivel up and go away. And if caught in time, it can be wonderful.
So that's interesting. So you're saying you're doing these laser treatments on parts of the eye that we don't use as much, and you're actually killing that tissue.
So they don't have them. They're not short on oxygen anymore because they're not there.
And you don't have to circulate anything in that dead tissue.
Well, no, it's like for the peripheral, like but the peripheral vision, not the goal is to maintain the central vision so that you can read, you can see where you're going, and things like that.
That's great. I mean, I didn't know that that's an option. So that's great. But I'm guessing, I'd be curious in all of your patients, roughly what percentage did have diabetes when you're dealing with older adults?
See, well, it's hard to tell because they're the ones who come in more because they have
True.
more problems. So
That's true. But I would think it sounds to me your advice is obviously manage your diet and your lifestyle to try to avoid the diabetes as much as possible. Do you have any advice that you would give to your patients, even if they weren't diabetic, on their dietary, and their lifestyle? What would you recommend to them for on that part of their life? Anything that would be helpful with staying healthy and keeping your eyes
don't
healthy.
don't eat too much, don't drink too much, exercise. Don't be overweight, don't be underweight. Underweight is not really a problem in the United States.
It is not. No. We have the opposite problem. Yes. Okay. But I think that's good. I mean, obviously it makes a difference, and I think I would want to do what I could to prevent from getting conditions like this, but especially when you say diabetes, it can affect everything in your body. So it is really important to try and stay not eating horribly, not drinking a lot of alcohol, um, definitely exercising every day, even if it's 20 minutes a day, do something. So I want to ask the question about sunglasses. Do I've heard, I don't know if it's true or not. I've heard people say you need to always wear sunglasses outside and protect your eyes from the UV rays or you can have eye problems. What do you say to that?
There, there may be some truth to that, but I would say that for normal things, it's probably not necessary. If you're up in the Arctic and there's ice all around and uh, all the rays are bouncing off the snow in your face, maybe. But in normal things, there are good reasons to use sunglasses, but I don't think that it's that big of a deal. More comfort and stylish also.
Gotta have the style.
Got it.
What about let's talk about I'd like to hear you say what you saw on the mental impact when people that you were treating, are diagnosed with a vision loss. What kind of impact did you see on their mental health?
It sucks. I mean, look, and
It does.
sometimes you say, "I'm sorry, I can't help you," or "I can't help you enough as much as
Mm.
you would want me to help you," and that's You know that if if there's some lady in Spain just died at 108 or something, if everybody, if we had all these answers, everybody would be 108.
Healthy, and yeah, you're right. So would you ever direct them though to like support groups, or is there anything that you felt was beneficial to them?
Everybody is different, and there's all sorts of groups. People. A lot of people just don't like to do it because they don't mind whining themselves. They don't want to hear other people whining. But this is a serious problem, is because people are having trouble as they get older and higher, and because people are living longer, more and more people are having these problems. And I don't mean to belittle it because these are serious, but
No, they're very
we're not
serious.
magicians.
That's the thing. I think it's obviously treatments have progressed, which is great, but like you're saying, sometimes that's all that you can do. I think it's just, for caregivers, we need to treat people with grace and understand that if we were in their shoes, we might be a little grumpy too, that we won't be able to do everything we needed to, used to be able to do. But maybe there's things at home in the house that you could make easier for them, whether it's, enlarging labels of things or making sure the shampoo and the conditioner are always in the same location in the shower, things that they stay in place so that the people, people are used to where they are. I think that would be helpful advice for a caregiver. Um, and I can look into if there's any support groups, nationally or anything like that. I do know that the National Public Library has great tools as far as the readers and magnifiers and that sort of thing that are they're free. If you have a doctor's order, you are able to get access to that information and it's sent to their house.
Yeah, there are some people who they will have it. They have a low vision clinic. I know there's one at Ohio State. Excuse me, the Ohio State University. But there's also there's a. I've been retired a couple of years. I assume he's still in practice. I think in Worthington, where he has a special interest in low vision aids. Now, these don't make the vision any better. They help you to function better with the vision you do have left. And there's no harm in seeing one of these specialists. Uh, but I think people go and have higher expectations than are realistic, especially if they're older. I think this may be an ageist comment, but the people who do best with low vision aids are younger people who have diseases that reduce the vision, uh, rather than macular degeneration, which affects older people.
Why do you think that is? That it's more that you feel like it's the younger, is it, do you think their mindset is
I
different?
assume so.
Interesting.
They're more in, I'm going to live another 40 years. I want to make it the best I can. If you're a 30-year-old with, say, Stargardt's disease, as opposed to somebody who's 70, says, I'm going to live another 10 years. I want to see better in those 10 years like I did all this time. The other people are more thankful, the younger ones are more thankful for functioning, and they're more malleable.
Isn't that interesting? I do think your
And I have no
mindset
idea if
has.
that's true, but
Yeah.
I
Well,
believe it.
I can understand that because I think you get. I don't mean this in a bad way because I worked in the home care profession for 20 years and people can get a little grumpy, when you're older and the body doesn't feel as good as it used to and it doesn't work the way that it used to. You're a little bit grumpy, and I think it's hard to keep that positive mindset of, what, I'm going to be grateful with what
Yeah.
I can do or with what I can see. And I think that would be an interesting psychology experiment because I bet you're right that um, there's definitely a difference in how people are receptive to the what they're able to do with the vision that they have. And I'll look into that. I'll put a link to that in our podcast show notes, because that the low vision clinic that you mentioned. So it's just an option if people want to research something like that. This was very interesting. Is there any other information you would want to share with caregivers? I feel like you're basically saying to us, get in and get your checkups, and make sure you're going to the ophthalmologist and get the screening done that you need to. And you mentioned the grid tests, which you could certainly do at home, I'm guessing, if you just even drew one.
No.
No?
You can get that. They're easy to get. You could probably download.
Okay.
It's called an Amsler, AMSLER grid. You can probably Google it and print out 100 copies.
Okay. I'll just send a link.
There's no secrets in this.
No, but it's helpful, because I think people don't know what they should be looking for. You gave very helpful information. I just think one thing I'm going to do is make an appointment soon to get my eyes checked, because I haven't done that.
Yeah, we got ophthalmologists, optometrists. We got to eat too,
I know you do. So I'll when I hang up, I will find I guess that's a question I'd ask is, if you don't have an ophthalmologist, do you have any recommendation for how people should find one that is reputable?
I would say go to Center for Sight in Newark, Ohio, because that's the practice I founded, but I no longer work.
I love that. Okay, I can go there. Now, what about people that live in a different state? Is there a certain website or anything like that used to be affiliated with?
You want somebody who's board certified and has all the credentials. And the best thing to do is ask your primary care physician or ask your friends and family who they might recommend. But these people, to be an optometrist is 8 years, I believe, of post-high school education. And for ophthalmologists, it's 12 years. And then if you're a subspecialist in either of the professions, if you decide to do a subspecialty, that's another couple of years, perhaps. So there's no such thing as a young ophthalmologist.
No, that's a lot. I'm impressed with what you've done. I'm very grateful. And it seems I now need to get you back to focusing on your Nobel Prize that you're going to work on. So you need a hobby if you're retired. So just start working on that, because
don't hold your breath.
Well, I'm so grateful. I so appreciate you being with us today. Thank you so much, Dr. Davidoff.
Thank you. Bye.
Thank you. That's a wrap for today's episode of The Care Table. Thank you so much for joining me. If you found this information helpful, would you subscribe, write a review, or share this episode with someone that you feel could benefit from hearing this information? I'd sure appreciate it. If you learned of anything during this podcast as far as books, resources, or products that you might think are helpful, be sure to check out the podcast show notes for links to access that information. A friendly reminder that this is not medical or legal advice. This is just information. Consult a professional for your own personal situation. I ask that God would bless you with the wisdom, the courage, and the strength that you need as you're navigating this caregiving journey. And I want to remind you, you are not alone. I appreciate you joining us today. And until next time, stay strong, and I hope to see you at the Care Table.